Well, good morning. Thank you again for being here. Every year we ask, should we do it again? And then we kind of get excited about it, and then we decide to do it, and then y'all come, and it's all worthwhile. So that's a very good thing. Number two is I think this is National Prior Authorizations Month. We were gonna note that, so I'm sure we all just need a little break from that. So maybe a little breakfast would be, a good thing, and then a little levity is always a good thing as well. And as you know, sometimes there's just excitement in the air, and one of the things for me is after all these years of saying to peanut allergic patients or atopic dermatitis patients, well, we'll keep doing what we're doing, hopefully something will be come along soon to change things. We're almost there, and it's getting really exciting, and so those are good things. So hopefully this year you'll come away with some real ideas about new things that are happening, and also changes in our strategies from the standpoint of how do we treat kids so that we don't have so much food allergy. So that's where we're going to go this morning. So thank you for being here. I'm thankful to our team for all the work they put in and set up. And please remember that as you come away from this, you just say, I've got a patient I need to talk to somebody about, or something came up with that, let us know. We'll work with you on that. So we enjoy that. So here we go, okay? So you're on call, and mom calls. And you may have seen this patient, you may not have. This is probably your patient, but mom has concerns about milk, soy, egg, and gluten allergy. Now, that may not be a big thing, but it sounds like it's about 3/4 of the food diet that they'd be eating, right? And there's been a few episodes of projectile vomiting and skin rashes that quickly resolve with Benadryl, okay? So anybody, what's your first impression right now? May have some kind of GI problem. If it's just a transient virus, it could cause these same things. Acute urticaria is either viral or allergic, and it's about 50-50 on that. So when I see a child who's having rashes, but it's been recent onset, obviously the food history is important, but it could be viral and it'll burn itself out after a while. So, but you look at this, and she's got an awful lot of concerns. Now, why does she have that? Well, the child had atopic dermatitis onset at about 6 months of age. Is that a risk factor for food allergy? Absolutely, and there's something on your desks right now, and we're going to talk about that before we're done with this lecture. That's a high risk factor, and now we're going to be using that as one of the factors that we say, where do we go from this as we look at 4 and 6 months of age, introducing solids and all that. So wheezing at 18 months, is that an issue? It is, isn't it? Yep. And diagnosed with mild persistent asthma by an allergist. That was probably Dr. Gerber, okay? So Dr. Gerber diagnosed them with mild persistent asthma. So that's pretty much under control. This presentation was skin and GI, wasn't it? Immunizations are up to date. Tolerated the influenza vaccine. What's underlying that? Egg allergy, exactly. Although there's minimal amount of egg there, but still egg allergy and all that. Now, we look at the records, and what do we see? The patient had an allergy evaluation at 18 months after the wheezing showed up, and we had this kind of persistent AD. This would be very typical for y'all to send, and it would be a great referral, obviously. Now, here's the consult note. There was some egg and peanut sensitivity, so the eggs are now integrated back into the diet. If you've been here for other presentations, you probably know egg is about 85% of the time, quote unquote, outgrown, right? So it's one of the allergens that's outgrown. It's also one of the allergens that's heat labile. So the more it's heated or baked, like baked egg will oftentimes be tolerated, but soft cooked egg, i.e. scrambled or whatever, is oftentimes not tolerated as long or as much until a little bit later on. And just from an example, I'm an atopic derm kid that grew up. My dad was egg allergic, but nobody knew that, okay? But yet he couldn't eat scrambled eggs his whole life, but he loved pancakes, okay? There you go, heat labile, heat stabile. He was one of the 85% that got rid of 1/2 of the egg allergen, but he was one of the 15% that held on to the soft-cooked egg allergy, and it caused GI symptoms, and he would sometimes talk about how his tongue felt itchy and all that kind of stuff. So those things are real, and they occur fairly commonly. What other allergen follows that same pattern to some extent? Milk, okay? So again, with milk, sometimes it's the cup of milk will cause the symptoms of GI or whatever, but if it's baked in the product, it doesn't. So there's a lot of mix-up. There's a lot of concern about, well, am I allergic or not? And the answer is, yeah, kind of, sort of. Now there are blood tests that are helping us to establish that and help with that as well. Okay, so peanut and tree nut avoidance due to AD. We're kind of changing our approach on that, but that would have been what we would have recommended. We got atopic dermatitis, we've got peanut allergy, this is a little kid, we've got to be safe, so consequently we're going to avoid peanuts and nuts right now. Yet, as you will see in many of the referrals to us now, one of the typical things we do is we scratch to something like almond, and then we'll have them bring in almond butter, and we'll see if we can introduce a substitute to peanut butter quickly because it's healthy, and it gives them that snack food that they want, and that's a good option. Plus, as we're seeing more and more, introduction and utilization in the diet is much safer than avoidance, which I used to preach 3 years. You know, if you had AD, let's stay away from all the highly allergenic foods till about 3 years of age. Then we modified it to 2. Now we're down to, 4, 6, 12 months. Let's get it in. So difference there. So we have that history. And then a sibling also had positive skin testing. So risk is pretty high, right? Okay. So what was the patient eating? 2% lactose-free cow's milk. Potentially allergenic, but skin testing previously was negative, right? Okay. And then chicken nuggets. What would be in the chicken nuggets? Breaded chicken nuggets, probably fried. Virtually all the allergens she was concerned about, right? Yeah. You've got the grains, probably wheat components, or you've got egg, milk. Wow. Okay. Soy, and then carrots with ranch dressing. How many of you have heard about like perioral rashes with ranch dressing? Okay. Topical egg, milk in there. Again, soy is in there. So you've got all the gamut. And then she also had some hummus. Okay. She loves hummus. Okay. Okay. The culprits. We don't have shellfish or fish that I know of in this one. That's the most common food in the adult that produces allergic reactivity. What is the allergen in this case? Chickpea, which is in and cross-reacts with, it's a legume. It cross-reacts with peanut. There you go, okay? So my first point today is the fact that we've probably done a poor job of talking about cross-reactivity. And yet, on the other hand, does every peanut allergic patient, do most peanut allergic patients have to avoid all legumes? No. But when we find a peanut allergic patient, special scrutiny toward the tolerance of legumes should be considered because a significant subset of our patients have reactions to peas, beans, soy, all those kind of allergens, and chickpea and hummus is one that I've had numerous cases of. So in this case, the hummus is the problem. It relates to the peanut allergen, which is a known issue, and so consequently that helps to identify it, and it talks about how this is a complicated factor, okay? What about these, okay? Peanuts, tree nuts, wheat and other grains, milk, egg, soy, and seeds. Now, obviously, in the first 3 or 4 years of life, milk, egg, and peanut are the biggies. Obviously, wheat is the next one on that line. But here in the low country, shellfish and fish get introduced very early. And so consequently, it is a consideration. But as you can see with the handout, and as we're going to talk about before I'm done, we're saying we should be introducing this early, but we should do it in a very unique way. The younger population, there you go. As you get to be more adolescent and adult, shellfish moves to the top of the list. And what's the classic history? I've never eaten before and it was the first time. No, I've been eating it all my life, and all of a sudden, the last couple times I've had it, my tongue got swollen, I had a little trouble swallowing, it can't be shellfish, I've eaten it forever. That's the typical history, isn't it? And it can progress. Severity, percentage-wise severity reactions, tree nuts are the worst for adults, but percentage of frequency of occurrence, it's shellfish. So, and seeds are becoming kind of our new recognized allergen, and we have to think about that with many of our salad dressings, with many of our garnishes and things like that. Sesame seed is actually the second most common allergen in India and Australia. So if it's endemic to the diet, oftentimes you will see things like that come. So sesame seeds, sunflower seeds, we're finding more and more patients where those are factors and problems there. So again, creative foods and the ability to have foods from all over the world and have new nuances to liven up our lives also does bring in new allergens. And then there's the intolerances, which is a whole other lecture. So the most severe, again, tree nuts in adults, peanuts in children. The most frequent, shellfish in adults, peanut in children, and resolution. And I'm putting this down because this is our known entity, about 20% peanut and tree nuts over long periods of time, and possibly to shellfish and fish. And another thing to remember is if you're allergic to shellfish, it's only about a 10% chance you're allergic to fish as well, and it could be individual fish because there's familial aspects, just as even in shellfish, there's the crustaceans, the shrimp, crab, and lobster, and then there's the bivalves, the oysters, clams, and scallops. And so consequently, again, you can oftentimes eat one and not tolerate the other. You just have to know what you're getting and make sure they were prepared separately rather than together. And then, of course, there's an 85% loss of sensitivity to egg and milk over time. Now, what is going on in food allergy that's important? Labeling. How many of you have had a patient come in and saying, well, everything says it may contain, what am I supposed to do? Anybody experience that? Anybody look at the labeling on the foods? I mean, in other words, from a medical legal standpoint, if it was processed in a facility where they may have nuts or peanuts at certain times, that has to be noted. You know, have you ever thought that that means that everybody's kitchen would be off limits? I mean, the reality of it is that's what's there. But the other end of it is, we don't know what the risk level is. The consumer doesn't know what the risk level is. And so part of the problem is we actually are still a little bit in the dark about the natural history of food allergens, especially the more severe ones. So interestingly, we're finding out new information as we speak now over and over again because of the studies that are being done. But, you know, there are people who, if they've been off peanut and they're still skin test positive, they still have blood tests that are positive, but as we break down the different allergens that we can now do in our peanut component tests and egg component tests and milk component tests, we're starting to understand why sometimes people are starting to literally have an accidental ingestion and not react. And it can be because their threshold of what causes the reaction is increasing, which means they may be able to have an accidental ingestion and succeed, but if they decide to have a handful of peanuts, we're going to be in trouble. So that would be very dangerous, wouldn't it? Because the information is going to not make sense. Can I eat peanut or can I not? And the answer still is yes and no. How much of it are you eating? How much has your sensitivity declined? And what is your potential for reactivity and where do you hit that threshold? We're learning more and more, but that's one of our problems. But educating about cross-reactivity, foods that might have the allergen in it, which foods would be most suspicious. In this little child that reacted, now that they're 2.5, 3 years of age, they were never positive to milk. On my scale, milk would no longer be the high threshold. It would have been, think about a legume or some kind of contamination aspect, okay? Because I wouldn't have expected a new allergen to milk to necessarily be the next thing that would happen. I would expect it more to be, it was peanut or something crossing over with that because that one was still active. Or there was something about the egg in the allergen where she was one of the reactors at that 15% interval where she was tolerating egg, but there was more protein because it was soft cooked or in a meringue or something like that, okay? Our fears and our concerns about food allergy in general are very important because look what's happened the last few years. How much did EpiPens cost? I mean, $500, $600, and $700 for EpiPens. Now that's being corrected as we speak. Okay, so there are, there's a lot of ways that have been put into place to bring those costs down, and that's a good thing, because that's been a hard thing for all of us as practitioners to say we've got to do what's right. It's like somebody telling you their airbag doesn't work and it's going to cost a lot of money to have the car fixed, but how can you say in good conscience, well, you don't need an airbag, when you know the next time they get in their car, they could have the very accident that requires that to save lives. So consequently, the EpiPen needs to be there, and yet many times we're not sure that it's necessary. Will the reaction ever get to that point? And we would like to be able to answer those questions. We're getting closer, so that's a good thing. But at least the crisis over cost of injectable epinephrine is improving because of changes that are being made right now. We are wanting to be able to be more, to talk about what can we do with little children, and I'm going to go over that little handout on your desk. And then the other thing is what about, can we desensitize people to food allergies? And right now, we are, through FDA-approved protocols, working on oral and transcutaneous desensitization to peanut allergen, and it's getting well publicized, it's getting in the paper a lot, and the fact is that system is going to be potentially usable for all those food allergies I listed right there. So milk and egg and shellfish and other tree nuts. We're in the era of jumping off into, if you're diagnosed with a food allergen, it's going to be treatable, and it's going to be treatable with a system you use at home, basically, whether it's a patch that you put on your back or whether it's a powdered protein food medication that where the known amount of allergen is there, where we can start so low that it is truly a desensitization. And these things are showing some really exciting results, and they're moving along very quickly with help from resources of all kinds and with FDA's clearance, because these are things that affect many people and there is no treatment. So that's why it's exciting. So for me, this is like one of those wonderful things that's happening at a time when for years you've counseled, in my 30 years of doing this, you counsel avoidance, and yet there's just, avoidance is only, it's a best effort, but it's going to be prone to failure at some point in time. And that's scary, and yet we're knowing more, doing more, and able to treat more effectively. Now, what are we doing about counseling families as to what to do? And just in the last few weeks, this has come out, this recommendation for practitioners and the recommendation for families. The high-risk atopic dermatitis or egg allergen patient, that's a high-risk patient. The patient where there's family history of food allergy, probably you should be very careful with. What about the patient where there's no atopic dermatitis, there's no food allergy whatsoever? The recommendations now, after having followed the LEAP studies, which are looking at early ingestions of highly allergenic foods, and especially peanut, was we should be feeding earlier. And but we want to feed with an appropriate type of thing. So the last thing we want to do is say, let's introduce peanut at 4 to 6 months of age, and then next year we're talking about all the choking episodes that have occurred because well-meaning people have tried to introduce sticky peanut butter to a child who isn't ready for it, or hopefully not, but peanut itself. But there are products that are there that can introduce peanut in smaller amounts that are easy to tolerate, and that's great. Or it can be something that has some peanut butter or something like that in it, some peanut flour in it, and so consequently introduce that food, and then all the other foods as well. If these children are moderate or high risk, if there's a family history, quickly getting either a specific serum IgE to the food allergen or a quick scratch test to the highly allergenic food allergens will say, if they're negative, let's move forward. If they're positive, then those are the ones to eliminate. Let's move forward with all the others. So now it's not, oh, no peanuts, no nuts. Now it's, well, we're peanut allergic. We don't have any problem with nuts. Let's look at almond or hazelnut. Let's see if we can introduce that with Nutella, almond butter, and such, and get that in again in the 4 to 6 to 12-month age range, starting to introduce those. So this is radically different than what we were saying not that many years ago. And yet now it's in writing, and it's encouraging us as frontliners to say, this is what we can do. And from our standpoint, we're doing tons of food challenges. I mean, it is not uncommon for us to do almond butter, Nutella challenges, peanut butter challenges multiple times a week, and more of that, so that the family can start to move along a very, very normal pattern of trying to introduce these foods that are easy, useful, and pretty much part of our cultural aspect of, all that, and that saves a lot of the social ramifications. My final point is the overwhelming burden of food allergy and the different ages and stages of it. It's very difficult for families. And so you get a peanut-free environment, but once you're outside the door of your house, it's not peanut-free. On the other hand, people say, why can't I just have a birthday party and invite kids, and then I've almost got to have a lawyer come over, or something like that. It's been difficult on all sides. And so consequently, if we can do a better job of actually treating, if we can do a better job of helping families to understand cross-reactivity, and if we can have labeling that talks about what risk are we really talking about, and to be honest, what risk does the patient really have, then I think we're going to really break through with this. Of course, my hope is when we can treat it and we can desensitize to it, that will take so much of the anxiety, so much of the burden, so much of the fear factor out, and it will really solve this. So the exciting thing is each year I look at, do we want to hear about food allergy? But it's changing rapidly, but now we're actually treating, and the projected goal is in 2 years this will be prescription available treatments. And so that's exciting. That is very exciting, and we are excited to be in the middle of it, because it just affects so many people in so many ways, and us as practitioners, we can now treat something rather than just give an EpiPen, hope for the best, and say stay away from peanut, and then when we get asked the questions, fumble because we don't know how to tell people how much risk there is in every given food. So that's my, it's a joy to be able to say this to you today, because this has really been a great last year and a half of advancement. Thank you.